thank you, Anna, and thank you everybody for being here today with us. As Anna said, if you have any questions, please just write it on the chat, and we will try to answer and discuss everything at the end of the panel. So I'm moderating this with Thorsten Kuhn. He's having kind of some problems connecting, so we will go ahead and while he stabilizes his connections. And let's just start by presenting the first speaker, who is going to be Tibor Kovacs. He has recorded his presentation, and he's going to give us an overview of the management of multifocal breast cancer.
Mr. Chairman, dear colleagues, thank you very much for the opportunity to present on today's ESSO webinar, and I would like to talk to you about the oncoplastic breast conservation for multiple ipsilateral breast cancers. I do not have any disclosures. As a definition, multifocal breast cancers are tumors which are located in the same quadrant with healthy breast tissue separating them on a distance of 2 centimeters in between. Multicentric tumors are located in different quadrants with more than 4 centimeters of healthy breast tissue in between. We can also nominate these tumors as multiple cancers within the breast. The incidence of multifocal and multicentric breast cancer is much higher than usually we think. This is an old study from 1985, which had a look into histologic multifocality of T1, T2 breast carcinomas, and also the implications of this in clinical trials of breast conserving surgery. What they've done is they've analyzed 282 mastectomy specimens with invasive index tumors, T1, T2 in size, and what they've seen that in 20% of cases there were further tumor foci within 2 centimeters from the index tumor, and in 43% of the cases, there were further tumors located more than 2 centimeters from the reference tumor. So even if on the investigations we could not find multifocal or multicentric breast cancer, it might be that within the breast there are smaller tumors, satellites present close or further away from the original tumor. The incidence of multifocal and multicentric breast cancer also varies a lot, in between 5 to 60% as reported in the literature. It is more common for lobular cancers, and the largest study analyzing more than 67,000 cases of multifocal multicentric disease showed a 9.5% incidence. Another retrospective multicentral trial with almost 9,000 breast cancers analyzed showed a 15.6% incidence. There is an assumption that multifocal and multicentric breast cancer is a contraindication for breast conservation. And why is that? There is a perception that there is a higher risk for local recurrence in cases of multiple invasive foci present due to the fact that we would leave some residual disease in the breast. And there is also a perception that multiple excisions from the breast or breast conservation can lead to poor cosmetic outcome due to the wider excisions or perhaps even quadrantectomy. The question is whether this is a true fact or there are certain perceptions which might not be close to reality. Multifocal and multicentric disease, is that a recommendation therefore for a mastectomy? So the original recommendation that multifocal multicentric disease would require a mastectomy comes from an old study and old studies back in the 80s, 90s, where the local recurrence rates were very high, 40%. These trials are more than 20 years old. The margins were not really sufficient in the excision specimens, and also the reports are based on small series. What is true that imaging and modern imaging technology has a significant role in deciding what procedure to choose, whether we should conserve the breast or whether we should do a mastectomy. And the MRI has a significant impact on the surgical decision-making process. What is true that the MRI can change the management of breast cancer surgical management in 38% of the cases, according to this study from 2017. And the MRI is also able to estimate the histological size within 20 millimeters size in 71% of cases. So preoperative MR scan most likely will find additional disease beyond the conventional imaging. So if you have a unifocal tumor on imaging, if we do an MR scan, most likely we will find more disease. Especially this is true for certain types of tumor biology, invasive lobular cancers, aggressive tumors, triple-negative breast cancers, also certain characteristics of the patient, such as dense breast or younger age. However, what is also true that the MR scan has a disappointingly high false positive rate. Also, 1/3 of MRI lesions are not cancers. So those lesions which are detected on the MR scan, if they are biopsied, they will not prove to be cancers. Using the MR can lead also to conversion from breast conservation to a mastectomy in quite a high number of cases, up to 25% of the cases. And also in Mayo Clinic series, the MRI scan increased the mastectomy rate from 38 to 52%, which is a real high mastectomy rate if we base our final surgical decision on the MRI scan. Therefore, we need a careful patient selection in order to avoid overdiagnosis. What is the surgical approach for multifocal and multicentric breast cancer nowadays, and what is the correct approach? Is breast conserving surgery oncologically safe? What kind of breast conservation should we do to achieve acceptable aesthetic results? And I can show you some literature data which supports that there is a place for the breast conservation in case of multifocal multicentric disease, and also the fact that the oncoplastic approach has a significant role to improve the aesthetic outcomes of the breast conservation procedures. So in this study, going back in 2008, which is a retrospective study with more than 400 patients with a median follow-up of 73 months, their cases were invasive lobular cancers in 18.5%, and they've also identified 3 or more tumor foci in 23% of the cases. Their local recurrence rate at 5 years, it was 5%. Therefore, their conclusion based on this limited study is that multifocal multicentric breast cancer is not associated with poorer local disease control if breast conservation is performed. In another study, for this, you need a larger breast size. The tumors are usually on an area which is more than 5 centimeters altogether, or 2 separate areas which are smaller. And these procedures, as compared with the standard breast conservation, can offer an alternative for a mastectomy. And as you can see in one of the fathers of oncoplasty, Mel Silverstein, he published his extreme oncoplasty data on a relatively low number of patients, as you can see in this study, 105 patients with more than 5 centimeters excisions. Their local recurrence rates are relatively low. And they also showed a re-excision rate of 12% for extreme oncoplasty and the conversion to mastectomy of 5%. Again, another example of extreme oncoplasty and how can we expand the indications for breast conservation. This is an observational cohort study published in 2019, so recent data for multiple lesions over 5 centimeters, therefore multifocal and multicentric disease. What is interesting that this study showed a 51.4% need for further surgery due to inadequate margins for a very large number of reoperations. Half of the patients, they needed second surgery. And out of the second surgery, 12.6% elected for a mastectomy. However, what they also say that those patients who had breast conservation, they had good to excellent cosmetic results in 95% of the cases, and they had a very low local recurrence rates, adding, of course, adjuvant radiotherapy. Therefore, extreme oncoplastic can be an alternative for a mastectomy, but we have a high re-excision rate, which we have to count with. And when we consent our patients, we have to tell them that there is a high chance for re-excision, need for re-excision, or even for a mastectomy, conversion for a mastectomy. Further studies are needed to determine the long-term oncological safety of these extreme oncoplasty procedures. And of course, for each and every quadrant, as you know, there are maximum tolerable volume losses. And this study from the National Institute of Oncology from Hungary, colleagues have assessed which quadrant is the most sensitive. And as you can see, the upper renal and lower renal quadrants with a high sensitivity of low volume excisions and poor cosmetic outcomes. So you can have to be careful if several areas of the breast has to be removed in order to not to compromise the aesthetic outcome of the surgery itself. How do we select the techniques? What we do for multifocal multicentric disease, what type of mammoplasty we would plan is also based on the BI-RADS density scoring. The more fatty the breast is, more often we have to choose the complex level 2 oncoplastic procedures, mammoplasty techniques. For the dense breast, oncoplastic level 1 techniques are the more suitable ones. And based on tumor location, breast volume, ptosis, we can choose the ideal techniques in different quadrants. Sometimes we have to combine different techniques or to use the same technique to remove tumors from different quadrants of the breast, such as a round block technique can be used for removing 2 or 3 tumors from different quadrants. And of course, on our assessment, we have to combine the type of the breast, whether there is ptosis or not, and also whether there is skin involvement, and also the location of the tumor. Another algorithm which helps to choose the right technique considers the size of the breast, small, large, or regular size, whether there is any ptosis present, and also different tumor locations, which they can define what procedure we would choose in order to achieve the best aesthetic outcomes with safe oncological outcomes too. The standardization of oncoplastic breast surgery is again something which is a very important issue to try to define for different tumor locations, breast types, and breast size, which procedure to choose, when to do oncoplastic conventional breast conservation, oncoplastic breast conservation, or when to do a mastectomy. All these algorithms are helpful to decide and to define what procedure to choose. Always to choose the simplest procedure with the best aesthetic outcome is a general advice. And of course, we have to consult with our patients to see what is their wish and what are their thoughts about how aggressive the oncoplastic remodelation should be. And quite often nowadays, we are talking about de-escalation of oncoplastic breast surgery to choose simpler procedures which can bring same as good aesthetic outcomes as the more complex ones. This older algorithm back from 2016 from Nottingham showed how the procedure complexity is increased based on the percentage of volume excised, also the volume of the breast and the size of the tumor. So the larger the tumor is, the larger the percentage of the volume what has to be removed is, and also the larger the breast volume is, the more complex procedures we would choose. It is very important that when we do the major mammoplasty techniques, such as reduction techniques, the localization, and after the excision, we should mark our specimen and we should provide our radiologists and radiotherapy colleagues with certain mapping of the breast and drawings where we would show which parts of the breast have been removed and how close they are to the nipple complex. Therefore, it is very important to correctly mark the tumor bed itself. And the challenge towards the radiation oncologists is when there is an inappropriately or poorly marked tumor bed, because the local boost for close margins have to be given to that area where the tumor was before, and the exact localization, it is crucial with insertion of the clips in the cavity in order to know exactly where the boost has to be delivered. If the boost is not delivered in the correct place, then this can increase the local recurrence rates, and the exact location in the breast of the excised tumor, it is mandatory for any oncoplastic breast conservation technique. So this is what, again, the surgeon has to be careful about. As a conclusion, I would like to say about the management of multifocal and multicentric disease, that there is a need for careful interpretation of the MR scans to avoid overdiagnosis and a high conversion rate to mastectomies. Wire or iodine seed localizations or any other different localizations techniques are very important to localize the multicentric multifocal disease, to correctly map the breast what has to be removed. Neoadjuvant systemic treatment can be always considered to downsize the tumor itself. And breast conservation surgery can be performed if each tumor focus meets the criteria of breast conservation, and if we can remove each and every tumor with clear surgical resection margins, which is confirmed by histology. Quite often, the approach which can be taken is the oncoplastic approach, oncoplastic mammoplastic techniques, in order to achieve good aesthetic results and safe cancer surgery. Due to poorer prognosis of these tumors, adjuvant systemic treatment has to be always considered. Overall, for multifocal and multicentric breast cancer, breast conservation surgery is a safe alternative, including the oncoplastic approaches, what we might have to take. Neoadjuvant systemic therapy, due to the poorer prognosis, should be considered, and also adjuvant radiotherapy. All these multidisciplinary treatment modalities can lead to an acceptable low local recurrence rate for multifocal multicentric disease and good aesthetic outcomes. Nowadays, in the current era, we are also facing and witnessing a certain swing towards offering oncoplastic procedures to almost everybody. And there is an evidence that there is an increased literature data, also a multiplication of oncoplastic courses, such as perhaps even ours. Quite often, surgeons might offer inappropriate extensive oncoplastic procedures in those cases where actually a standard breast conservation is an appropriate surgery, perhaps combined with level 1 techniques. So we have to think about how can we de-escalate surgery in order to offer a safe, oncologically safe, and also aesthetically pleasing surgery for our patients. With this, I would like to finish my lecture, and I would like to thank you very much for your attention. And I would like to remind you that the website of the breast surgeon certification program led by ESSO and other major European breast surgical and breast cancer societies are discussing about the certification process of breast cancer surgeons. And with this, I would like to thank very much for your attention, and thank you for the opportunity to present this lecture. Thank you again.
Well, thank you to Tibor, although he's not here. Maybe, Thorsten, if you think we can answer 2 or 3 questions, because there are all about multicentric tumors, and maybe we can just answer those questions now and then go through the other, or we just wait for the discussion. Do you have a good connection, or?
Well, we can try. So very sorry for me, but we have been in a traffic jam on the highway, and this was really a problem for the internet. Can you hear me?
Yes, perfectly. So
okay, so thank you, Tibor, for this very nice presentation. So I have one question for this that we might discuss with Ulrich. So in case of multicentric or multifocal or multicentric disease, and we need a boost irradiation of the tumor bed. I think we have 2 options. We have one specimen or we can have two resected specimens, specifically in multicentric disease. How do you handle the indication for boost irradiation? Certainly we put clips in, but is it feasible, this is a question to Orit, to have two boosts in one breast, or how should we handle the problem?
So this is quite a challenging question because there is no consensus for the indication for a boost with regards to risk factor. Definitely for a patient with multicenter or multifocal, there is a tendency to give boost, but if the boost volume is too large with regards to the breast volume, it's very difficult. And it's prone for more complications and fibrosis associated with radiation therapy. So often if the boost volume is quite large, it is often omitted and not done. And as Tibor indicated, there are several ways to how to mark the boost area, even in cases of oncoplastic surgery. And it is highly important to have good communication with your surgeons. I often call my surgeons and say, hey, I need your help. You did oncoplastic. Can you tell me whether these clips are associated with the tumor bed or only just to indicate of the plane of the surgical procedure? So communication with the surgical team is highly important.
Yes, thank you, because this was one of the questions from the audience, and I think you have very well answered it. And I think that there is also one question about if there is more than 3 places of multicentric cancer, then would you advocate breast conservative surgery or mastectomy? Well, I'm gonna answer, and then maybe Thorsten, you can answer too. I think that it always depends on what is the size of the breast, where are the lesions located, how can you perform the surgery, if you can do I, for example, operated on a patient the other day who has a multicentric cancer, one in the upper outer quadrant and one in the upper inner quadrant, but I could do it through a round block incision, and we just did fine because we take, I think that one of the most important things is that you can take all the lesions through the same incision. And I think that's one of the things about oncoplastic, that you take all the tumors through the same incisions. And I think that's, so it's not a matter of how many lesions, it's a matter of the size of the breast and where the lesions are located. What do you think, Thorsten? Okay, I don't know if he's
also a matter. The distribution is also of interest. You know, are the foci in a segmental order? So this is very easy for the surgeon to resect tumors at several centimeters distance because they are in a segment, and it's more easy to resect. And I would absolutely agree that we should try to only have one incision, and the second one is to, if possible, to remove the tumors with one specimen.
Yeah, there's another question that says, if the patient has Paget cancer and there are 2 tumors under it, infiltrating carcinoma, is it possible to perform breast preserving surgery? Well, it depends also, you know, what's the size of the breast, because we have a technique for those tumors who are invading the nipple areolar complex or are under the nipple areolar complex, that it's called the Grisotti technique. And sometimes if you have enough pedicle from the nipple areolar complex to the inframammary fold, you can use that technique and you can excise completely the nipple areolar complex and the tumors below it. So I think it's an appropriate technique for this type of tumors. Okay, my questions. In the multicentric lesions, do we have to excise all the cancer together in one specimen? Well, I think we already answered that. So So you got that answer. And there is another question saying, frozen section in multifocal or more so in multicentric tumors? Do you do any frozen section? No. We don't do either frozen sections. We usually send the specimen to be macroscopically evaluated by the pathologist, but unless there is something that we are worried about, we usually don't do frozen section intraoperatively. You don't do either, right, Thorsten?
Yeah, may I just ask, was it meant for the frozen section for determination of the margin width?
Well, they didn't say, they just asked about frozen sections. Yeah.
Because you know, there's another issue for me, and we saw the very good data on multifocality and multicentricity from MRI. So in my institution, we have a very strict rule that we never extend the surgery only because of the result of imaging. So if we extend surgery from simple wide local resection to oncoplastic, or from oncoplastic to mastectomy, this is always based on histology, because we know of the high false negative rates of any imaging techniques, specifically MRI. So this is a very hard rule that I have.
Yeah, I agree that with the imaging, and mainly if the patient has an MRI. I think there is another question from Ernest Luiten, and I'm glad that he is here with us. And he's asking about, Orit, this one is for you. Is there any experience with intraoperative radiation therapy of the lumpectomy cavity? When do you have preceding displacement techniques? So in the oncoplastic surgery, what about intraoperative radiation therapy?
This is a great question, and I think this will be a part of the future of radiation oncology, is to use the intraoperative technique in order to allow for oncoplastic surgery, because it's often very difficult to give a boost after oncoplastic. We often omit the boost because there is a lot of displacement of healthy tissue around, and we don't actually know where the actual tumor bed is. So with the use of intraoperative technique, so there is some experience, but only a few reports, not really large studies about it.
Yes.
Great question.
Yeah, we usually are doing this in some of, we have the electron intraoperative radiation therapy at my institution, and we are using it in some of these oncoplastic techniques, because it's true that once that you start removing or remodulating the breast, then, you know, things get worse for the radiation oncologist. Yeah.
Yes.
Okay, so I think that we can move to the next speaker, that it's me, by the way. So let's move to the next one, and then we can have another questions, because now we are going to talk about neoadjuvant treatment and how do we do the surgery after neoadjuvant treatment. So let's just go for that. Okay, share screen. Can you see the slides?
Yes.
Okay, good. So I just changed a little bit the title of the session, just because I think it's more interesting to see if we can de-escalate surgery in primary tumors after neoadjuvant treatment. I have no conflict of interest, and we already know, and is this just a little review of the advantages of the neoadjuvant treatments. And we know that we can monitor the response to therapy at an early stage. We can downstage the tumors, not only to preserve the breast, but also to de-escalate the treatment of the axilla. We will have time to do a mutation test for a germline mutation, even though in many institutions now it just takes a couple of weeks. We can also provide individualized post-treatment prognostic information for additional adjuvant treatments. And I think this is a point that has been increasing importance in the last years. And of course, we can expedite new and better drug development. So how do we choose neoadjuvant treatments? And I think that when we face a patient, we need to take into account several factors. And one is, the tumor subtype, the stage of the disease, and the patient characteristics and the desire. And if you use neoadjuvant treatment, it may change surgical options depending on the response. So that's another factor to take into account. Of course, I'm just gonna say something about the HER2 positive and the triple negative, because I think that nowadays it's clear that in those patients with this type of tumor, if they are stage 2 and stage 3, the neoadjuvant treatment is clearly indicated. And sometimes where do we have the problems or the difficult decision about whether to give neoadjuvant treatment is when the tumor is less than 1 centimeter and sometimes between 1 and 2. I think that in these cases, we need to realize if the patient will receive the same neoadjuvant treatment before and after, then we'll give it before, because in the HER2 positive patients, mainly also in the triple negative, you can change the treatment depending on the response. And usually, when the tumor is less than 1 centimeter, we usually go to surgery, because in that case, sometimes it's difficult to define if the treatment before and after will be the same, or if you have a clinical trial, then you put the patient into a clinical trial. And there are some surgical principles in breast conservative surgery after neoadjuvant treatment that we need to be careful, because they are so much important for the success of this de-escalation. We need to mark the tumor before start the treatment, and this is something that is completely important, because if the patient has a complete response, then we won't know where the tumor is. We need to make sure that the volume of excision is based on post-chemotherapy assessment and not on the pre-chemotherapy size. And this is already been studied, and even though it was controversial many years ago, nowadays we know that this is the way to go. And we also leave clips in the tumor bed for the radiation therapy planning. And this is also important, because as we have seen, sometimes for them, it's also very difficult to know where to place the boost. We need to assess baseline characteristics and post-neoadjuvant treatment characteristics to the size and the type of surgery. So when we see the patient, we tell her, we are going to give you neoadjuvant treatment, and if this is the response or this, we may change the type of the surgery. And also important is that the cosmesis should not compromise oncological principles. Sometimes there is no way you can do a breast conservative surgery, then the patient will have a mastectomy. Of course, we already know that for us, the main problem is to find out what's the tumor response before doing the surgery, because we know that even with the best radiological images, and the MRI is the most accurate in determining the response, there is still patients where we don't really know what the type of response is until we have the definitive pathology. It's important that the patient is seen in the multidisciplinary care, and it's also very important that the patient is seen by the surgeon before starting the neoadjuvant treatment, because we need to assess what is the type of surgery we should do if we do surgery first. It's also important to use the preoperative imaging according to the stage and presentation, and use the same method that we use at diagnosis. Why I'm saying this? I'm saying this because if the patient has for preoperative imaging at diagnosis a mammogram and ultrasound of the breast and the axilla, but they don't have an MRI, unless there is a problem during the chemotherapy that you're not sure whether it's progressing or something that it's completely unexpected, then you don't want to use an MRI before the surgery, because you don't have anything to compare to. So it loses a little bit their really use. Surgical resection is planned and conducted according to imaging before the surgery. So we assess the patient again before doing the surgery. We remove all the residual disease, and in case of a radiological complete response, we remove the clip with a rim of tissue and place the clips in the tumor bed. And answering the question, the talk from Tibor before, this is a patient who has a multicentric cancer. You can see here on the left, HER2 positive patients, we placed 2 clips. She underwent a complete response, and we did reduction mammoplasty on the patient. Of course, rates of breast conservative surgery after neoadjuvant treatment has been increasing over the years. And in the first years, those rates were very low, but nowadays in the newest reviews and studies and clinical trials, it's approached very much the PCR. So there is no point to increase PCR with systemic treatment and then drive the patient to have a mastectomy when she can have breast conservative surgery. And we already know that those patients who has a pathologic complete response, mainly in the HER2 positive group, the 5-year local regional recurrences are much lower than if the patient do not have a complete response. So we already know from many studies that pathologic complete response is a prognostic factor in these patients. And then in the last years, the question has come as if we can de-escalate so much the surgery that we are not going to do surgery anymore. And in those patients who had a clinical complete response, and this is a study that was published by several groups who are already participating in clinical trials for avoiding the breast surgery after neoadjuvant treatment. And as you can see, the sample of the tumor before the surgery is so important to assess the response. Mainly, they found that there are some characteristics that you can have, like using a vacuum-assisted biopsy, retrieve more than 6 representative samples of a tumor bed that measure 2 centimeters. So you more or less take a lot of tissue, so you can lower your false negative rate. And as I say, there are many, there are 2 or 3 already clinical trials ongoing of this. So what about the axilla? We also have learned in the last years that in those patients, HER2 positive patients with the addition of a dual blockade, the percentage of complete pathologic response can be as high as 70%. And in this study that we did in our institution, 75% of the patients has a pathologic complete response, those patients who were clinically positive and proven biopsy by that. In those patients with a clinically negative axilla before the neoadjuvant treatment, we know that sentinel lymph node biopsy is safe and is accurate because we already have all these studies with meta-analysis showing that the false negative rate is low. And even more, we have that the regional recurrences in many studies with follow-ups of 5 years, 3 years is very low in the axilla in those patients with a clinically negative axilla who undergo sentinel lymph node biopsy after the neoadjuvant treatment. And even more, we have seen that in those tumor subtypes like HER2 positive and triple negative, the breast PCR, so the pathologic complete response in the breast, is highly correlated with the nodal status. So in those patients with a clinically negative axilla and a pathologic complete response in the breast, the risk of having any positive sentinel node is so low. And after all these studies, the second question is, so can we just don't do a sentinel lymph node biopsy in those patients who are clinically negative and has a breast PCR? And there are 2 trials ongoing for no axillary surgery in clinically negative axilla after neoadjuvant treatments, one from the EU breast group and another one from the Netherlands Cancer Institute, and we will have the results in some years from now. So in those patients with a clinically positive axilla that we have known from several studies that the false negative rate can be higher than 10% or at least 10%, can we reduce those false negative results? And the new thing in the last 5 to 6 years has been to place a clip in the biopsy node at the time of the diagnosis, and then at the surgery we remove the lymph node that we knew has the disease, and is the axillary lymph node with the clip, and then the lymph node that is most likely to harbor the disease, and the sentinel lymph node. And this was called by the group from MD Anderson the TAT procedure, because we've learned that when you use the TAT procedure and you excise more than 2 sentinel lymph nodes, the rate of false negative is very low. This is from the study of the ESSO 71, and you can see here that when they excised 2 sentinel lymph node, the clip node was the sentinel lymph node in 75% of the cases, and the more sentinel lymph node that you excise, the more chances that the clip node was the sentinel lymph node. We've seen also that if you only excise the clip node, the false negative rates can be higher than 7%. And there are here many studies already looking at this TAT procedure with different types of techniques. Some of them use seed, other clips. Our study, we use a clip that was visible under intraoperative ultrasound. Other groups excise with blue dye and a clip, black ink, and you can see all of them that the rates of false negative are below 10%. And more meta-analysis showing that if you use a clip, you excise the sentinel lymph node, the chances of having a false negative rate of the sentinel lymph node is as low as 2 to 4%. So it has been clear that this way of performing the de-escalation in the axillary surgery after neoadjuvant treatment in patients with clinically positive axilla yields a very low rate of false negative. This means that everybody needs to place a clip. Well, there are some groups and some institutions like the group from Memorial that excise 3 sentinel lymph nodes and don't place a clip, and they also has a very good false negative rate. As I mentioned, we put a clip that you can see under the ultrasound, and we excise it with the intraoperative ultrasound. We have a very small probe that we can even put through the axilla. When the sentinel lymph node is positive, it is necessary to complete an axillary lymph node dissection. And there are some studies here that shows that with macromets, there are more than 50% of chances of having additional positive nodes. With micromets, there is also a higher chance of having a positive node. Even with isolated tumor cells, the chances of having positive nodes are high. Even though, as you can see here, ITC are very low numbers, but even though you can have as much as 50% of patients with another positive nodes, and it seems that after the adjuvant treatment, these patients are the ones who are not responding well to the treatment. Of course, if you have a patient with a positive axilla who had a sentinel lymph node biopsy and it came back negative, and you don't do an axillary lymph node dissection, there are not many much into the follow-up to know if this is enough and you don't increase the local recurrences. There are only 2 studies, one from Galimberti that shows that there were no nodal failures up to 62 months, and then other one with a very low follow-up of 9 months. So it seems that if you perform the sentinel lymph node biopsy following the indications, because the technique matters, in some patients, it seems that there is no increase in local regional recurrences if you don't do an axillary lymph node dissection when all the sentinel nodes and the clip nodes are negative. So this is how we manage the axilla after neoadjuvant treatment. If there is a clinically positive axilla, we use dual mapping. We retrieve more than 2 sentinel lymph nodes, or at least 2, and we also excise the axillary node, and we do the axillary lymph node dissection if there is any positive sentinel node, if it doesn't map, or if we don't get more or at least 2 sentinel nodes. Sometimes if we get patients who doesn't have a clip and the axillary ultrasound before surgery don't see any suspicious node, we usually ask the pathologist to look for the presence or absence of changes in the sentinel lymph nodes. And in some groups where they don't place a clip, they excise a minimum of 3 sentinel lymph nodes. I'm not going to go through this because there are many studies, ongoing trials in clinically positive axilla, looking at the role of radiation therapy, and we can discuss this with Orit after her presentation about, whether the patients need radiation benefit from radiation therapy, whether the radiation therapy can replace the axillary lymph node dissection in some cases or not. Also want to remind you that we have this international registry from the EU breast group to look in a prospective cohort the different type of techniques that the institutions are using in these patients with a positive axilla and evaluating the follow-up. So it's open to recruitment. So if you want, just visit the eubreast.com and look there to the protocol, because we already have more than 800 patients registered there. And Thorsten, who is the PI, will be very glad to say something more at the end of this session. A couple of words, and just to finish, about the patients who had luminal B tumors, that for me in this case are the more difficult to decide whether to undergo surgery or neoadjuvant treatments. And I'm not going to go very deep into this, just a couple of things to remind that we need to take into account many factors, a little bit more probably than we used to with the HER2 and triple negative. And I think that it's important, the hormone receptor intensity, the KI, whether the patient benefits for surgery if they have a reduction. And in some cases, the genomic platforms can change the immunohistochemistry of the tumors and can help us to decide whether the patient will benefit from neoadjuvant endocrine, chemotherapy, or surgery. So in conclusion, I think that the increased rates of PCR are mainly in high-risk breast cancer, and I think that this has been followed by increased rate of breast conservative surgery. We need to lose to be afraid of doing breast conservative surgery in triple negative breast cancer, because we have enough evidence that is as safety as a mastectomy. And in those patients with clinically negative axilla, we do a sentinel lymph node after neoadjuvant treatment, and if it's N0, we just don't do any axillary lymph node dissection. And in the clinically positive axilla, we do the sentinel node, we excise the clip node, and depending on the response, if it's a pathologic complete response, it will receive radiation therapy or not, depending on the initial stage, and we can discuss that too. And if the patient still has positive nodes, we do an axillary lymph node dissection. So I will stop here, and maybe we can have we can have your talk if you want, or we should go through a little bit. Oh, Thorsten, you are already in your house? Good.
Yes, I'm back.
Good. Good.
This was not easy, but I could hear everything that you said. So thank you very much, Isabel, for this really excellent presentation. It was it was really great to listen, even in the car and coming back and so on. Crazy
So
what is possible today.
We have several questions. Do you want us to go through it, or in the chat, or we just hear Orit and do the
I don't know. I think there are so many controversial issues. I think it might be good to go into the questions right away, as we did for the first presentation, but I'm open for it.
Okay, so let's see. Do you do MRI before and after neoadjuvant treatment? I do. If I do MRI before, I always do it after, but I don't do it always before. Okay, what do you do, Thorsten?
Well, it's we do not recommend standard MRI in our guidelines, but in my department, we usually do it because it's the best. For me, it's the best technique, although there are data showing that ultrasound is not worse than MRI. In my experience, this is not so. and we like to have a standardized procedure that is reproducible. So I like MRI a lot, especially when we decide on complete PCR on imaging. You know, this is a precondition for the UBreast-1 trial that you mentioned that omits X-ray surgery in HER2 positive and triple negatives. So I like MRI, but it's not everywhere, not included in the guidelines.
Yes, I do in selected cases, many cases. I mean, HER2 positive and triple negative, all. In multifocal disease, do you mark every separate lesion? Yes, you need to mark every lesion, because if they disappear, then you don't know where they are. Yeah. How much breast tissue needs to be excised? How far from the clip needs to be excised in patients with complete response to chemotherapy? Thorsten, how much tissue do you excise?
Well, there is a recommendation, I think from, I think it was from the BIG. There was a paper published 2015, and there was a consensus conference on how to standardize procedures in the neoadjuvant setting in order to make trial results comparable. And in this paper, it is said, and this is the rule that I follow, that all disease that is visible on imaging should be removed, including the clip in the PCR in the breast, and the margins have to be free. So these are the criteria. So every lesion visible on any imaging procedure, clear margins, and the clip.
Yes, I agree. So there is another question about inflammatory carcinoma. Would you consider breast conservation for the complete clinical and radiological response following neoadjuvant treatment in inflammatory carcinoma? No, no. And I think unless you are into a clinical trial, inflammatory carcinoma is a contraindication even if it has a complete response. There are some initial studies with breast conservative surgery that hasn't had very good local regional control. So how could you approach the axilla in cases of neoadjuvant? Do you advocate targeted axillary lymph node dissection? Well, yes, I am really an advocate of the targeted axillary. I clip all the I clip one node if it's positive, and I always do that, you know. So do you do that also, Thorsten?
Well, I think thank you for showing the AXANA trial, and for showing all the data on false negatives rates. And the rationale for the AXANA study as a prospective registry is the fact that we can compare false negative rates of different staging procedures, surgical stage procedures in the axilla, but we do not have any data how false negative rates translate into invasive disease-free survival and life quality. So that's the reason why we designed the AXANA study as a registry, because there are many different techniques, and we do not know if the reduced false negative rates of target axillary resection will translate into reduced recurrence rates compared to sentinel lymph node biopsy. And Isabel mentions the paper from Viviana Galimberti. After 10 years, there were, I think there was one X-ray recurrence among 270 patients who were CN1 or 2 and converted to YCN0. So maybe simple sentinel lymph node biopsy. And it's important to note that Viviana Galimberti, she does not resect 2 or 3 sentinel nodes. She resects 1 sentinel node. She does not use combined techniques. She does a simple sentinel node biopsy technique. So this is very interesting to me. So at the moment, I think data are convincing to use some technique to locate the lymph nodes when we think about false negatives. But in the end, we do not know if this is really necessary. And the second issue, just a short comment, if I may, that we have little information on the or the technique to mark the lymph nodes. We have visual techniques like charcoal. We have clips and coils that need imaging guiding. And we have probe guided techniques like MAX-seeds, radar reflectors, or nuclear seed. So these are very different techniques, and we try to compare different techniques for the detections rate, because the clips have detections rate between 70 and 98%. So which clip? So there are many open issues.
Yeah. So Orit, what about radiation therapy to the axilla? We are so the question is, do we still consider only a stage of disease to irradiate the axilla regardless of the response? So in patients with clinically positive axilla, even if they have a complete response, do you recommend the irradiation of the nodal basins?
This is a great question, of course, because we are awaiting of the outcomes of current clinical trials that matter, like the RTOG trial, NRG trial. But I think Philip Putmans had a great figure in one of his editorial in the Lancet Oncology that showed that local regional treatment has great value if we have little disease left. So if the patient had a complete response, we assume that we might have a few tumor cells that are out there. And by giving local regional treatment, I think we can improve outcome. Until further data from the NRG trial, I would irradiate those patients.
Good. Yeah, I mean, our radiation oncologist does the same. I was, I don't know, I was the other day in a meeting, and someone say, well, you know, now the patients, now that we are telling the patients that breast conservative surgery is safer or better than mastectomy. One of the reasons not to have mastectomy is because radiation oncologists are irradiating much more mastectomy patients. So, you know, that comes up to the top of the radiation. Well, I mean.
Yes. So Elzbieta gave a great presentation about this topic in, I think it was in the EBCC, and she summarized this into a manuscript. So I hope it will be published soon. All the aspects of treating the axilla after primary systemic therapy and the controversies.
So let's go through a couple of more questions, and then we will let Ori give her presentation. Do you have a limited number of involved pre-chemo nodes? Do you mark 2 nodes if only 2 are suspected? Well, I can tell you that I only mark the node that I biopsy and it's positive. I usually, and I don't think there is a rule for that, but we usually start, when we start doing this TAT procedure and the sentinel node in the neoadjuvant setting, we usually try to not doing these procedures in patients who has N2 outside a clinical trial, or if they have more than 4 clearly suspicious nodes under ultrasound. So in those cases, we mark 1 node and we do the sentinel node and the TAT procedure, but we always follow with a axillary lymph node dissection, and we will await for that data. But we only mark 1 node. What do you do, Thorsten?
Well, we do similarly, and I can tell you the first results of the Axana study, because all these uncertainties we assess in the Axana study. We want to know what people do in reality. And I think according to our last interim results, 73%, I think, of surgeons mark only 1 lymph node. There are some who mark several lymph nodes, up to 2, 3, 4, or every lymph node, but this is experimental. We do not know the effect on outcome. And this is exactly what we want to look at in the Axana study. Also, I think there is some kind of feeling not to include N2 patients to minimally invasive surgery, diagnostic surgery in the axilla. But I think it's a feeling we do not really know. Most of us are reluctant to include these patients for central lymph node biopsy or target axillary dissection, but it's a little bit of gut feeling. But I think I agree that there's some kind of consensus not to do these techniques in patients with high tumor load in the lymph node regions.
Okay, well, we will let Ori to give us some of her expertise in the radiation therapy field. So, everyone.
Thank you.
Let me introduce just, because, you know, everybody knows you, but just in case, Ori Kaider is working at the Rambam Medical Center. She's a radiation oncologist in Israel, and we are very glad to have you here.
Thank you very much. So I'll be speaking about radiation after immediate breast reconstruction. I'm working actually at Sheba Medical Center. It's in Ramat Gan. I have no disclosures, but I'm a full-time radiation oncologist. I'm a clinician working with a multidisciplinary team at a large tertiary center in Israel. And I'm also a PhD student at Mastro. And my work is, part of my work is I'm working in collaboration with different society, including ESSO and EUBreast, and aiming to improve the outcome of the patients who are undergoing mastectomy and breast reconstruction and are receiving post-operative radiation therapy. And since I'm working with a lot of different experts from different countries, I was surprised about the completely different approach to breast reconstruction and post-mastectomy radiation. And as you probably all know, the outcome of reconstruction surgery and radiation is poor. Radiation increases complication rate, regardless of the timing of the radiation. And in this slide, you can see the complication rate in case of autologous flap reconstruction. And you can see here that if the radiation is given before, as part of breast conservation therapy, and then the patient is undergoing mastectomy either for recurrence, or if the radiation is given to the flap in case of immediate breast reconstruction, we have relatively high complication rate. But in case of autologous flap, we have 1% report of failure in case of the radiation given before the flap reconstruction, and up to 4% flap failure if the radiation is given in case of immediate reconstruction. And of course, we have flap fibrosis and more volume loss in case of the radiation is given to the autologous flap. And how about implant-based reconstruction? Radiation increases significantly the complications associated with implant-based reconstruction. You all know, are familiar probably with capsular contracture, but also increases significantly the failure rate of an implant. Up to 20% of the patient with implant-based reconstruction will have a failure of the implant. So, as I indicated, radiation is associated with increased risk of complication regardless of the timing of the radiation. Post-mastectomy radiation for many years was limited to more advanced disease due to the toxicities, and patients who were planned for radiation underwent mastectomy without reconstruction. And if reconstruction was desired, delayed autologous-based reconstruction was the preferred approach, because autologous reconstruction is a delicate procedure and subject the patient to donor site and recipient site complication. And if it fails, it might leave the patient without any other options of reconstruction. However, a publication that was published in 2015 indicated the data from the SEER data from the North America, from the US, showed that we have increased rates of immediate breast reconstruction and mostly increasing the rates of implant-based reconstruction in patients who are planned for post-mastectomy radiation. As you can see in the figure, the autologous only flaps are decreasing, and the implant-based only reconstruction is increasing in patients who are planned for post-mastectomy radiation. And this is another report from the US indicating that patients who are eligible for breast conserving surgery, they reported more patients that are undergoing mastectomy and immediate reconstruction, and more patients that are undergoing bilateral mastectomy for a unilateral disease with bilateral reconstruction. And you need to remember that these patients, even though that they're eligible for breast conservation, they might need post-mastectomy radiation because the indication are mostly node-positive disease, but also high-risk features. And the implants are associated with poor outcome, more complications, more failure, and less satisfaction, especially when it is associated with radiation therapy, but yet we are seeing increasing rate of immediate reconstruction, implant-based reconstruction. And why is that? So maybe it is also associated with the trend of breast augmentation, not in the case of breast cancer. In this figure, you can see the popularity of breast augmentation in the population, and maybe this is indicator of a popularity of the procedure and familiarity with the procedure. And this is not a scientific table, but I made it just in order to understand more why we know that immediate breast reconstruction with an implant in patients who are undergo radiation do poorly, but yet these rates are increasing. And we have patients factor that might influence, they can decide on the size and the shape of the implant, like augmentation. They don't want the ptotic breast that are assumed to be with more autologous breast, less donor site. Immediate reconstruction, we know that has psychological effect and quality of life implication after mastectomy. The insurance, at least in the US, covers both breast, even for a unilateral disease. And overall, we have some reports that indicating that even with implant-based reconstruction and radiation, some of the patients are quite satisfied and even would choose the same method of reconstruction. With regards to the surgeons, so it's less technically demanding than the microsurgery and having an autologous flap, shorter operative time, avoidance of donor sites, potential shorter recovery for the patient. In some countries, it is even better reimbursement for implant-based reconstruction. And despite the higher rate of capsular contracture, aesthetic outcome in some of the report were reported good to excellent. So maybe in some cases, the implant-based reconstruction with radiation is not doing so bad. But this is the reality that we live in. The mastectomy and implant-based reconstruction are increasing, but also increasing rates of post-mastectomy radiation. And this is mostly due to the EBCTCG meta-analysis update published in 2014, but also, as we heard before, the de-escalation in axillary surgery, including in node-negative patients. And this is a nice paper by Birgit Offerson and Philip Pultmans, which discusses the indications of post-mastectomy radiation in this area. With the new trials and with primary systemic therapies, and why many patients who are node positive, even 1 to 3 node, should receive post-mastectomy radiation. So surgery has made significant improvement over time. You can see the Halsted procedure and the total mastectomy in this patient. And you made such an improvement, and from radical surgery to shaping the skin of the chest wall to create the neobreast. And if someone doesn't recognize, they put Zoltan Marti, which is a great surgeon and a great colleague. And radiation also made significant achievement over time. From bony landmark, we moved to volume delineation and dose painting. And the future of radiation is yet to come with incredible progress that was done over a long period of time, mainly by the UK team with the import low, import high trials and fast forward trials. So we have a long way to go and the future is yet to come. But in order to improve outcome of those patients, we need to work together, and I hope that I will show you why. And we are doing a big effort. This is part of the work includes an international multidisciplinary team, and we already published 2 papers, and I marked the surgeons on our team. We have a multidisciplinary and an interdisciplinary of surgeons, and also a pathologist, radiologist. We're all working together to improve the outcome of radiation therapy in the setting of immediate reconstruction. So as a radiation oncologist, we need to be active and we need to be involved prior to surgery and be involved in the multidisciplinary and before surgery. It is advised to recommend breast conserving surgery, and Tibor demonstrated great in his presentation that you can also do breast conservation and oncoplastic in patients with more extensive disease. Assess the chances for radiation therapy post-mastectomy, the benefit and risk prior to surgery, identify the patients who are prone for complication and poor outcome. It is important to know that radiation is limited in treating gross disease because of dose and toxicity, and radiation is aiming to treat microscopic disease, the high-risk areas of recurrence. And surgeons have a major role in helping us to make the radiation successful in this part. We can define the volumes to treat and protect, but we need your help, as we discussed before, also about the boost. We can define the dose, fractionation, and radiation plan and constraints, but we need more work on an international level. And all those factors matter for reducing the toxicity and controlling the disease. And this is an example for how important it is to choose the right surgical procedures. The first one is multifocal disease. The patient had a few foci. According to the PATH report, all these known disease foci were taken out, but by the time she underwent mastectomy and immediate reconstruction with an implant, and by the time she was referred to our institution for radiation, she already recurred at the subcutaneous, as you can see in this figure. And the other example is another poor selection of patient. We spoke before about inflammatory disease. So this patient had suspected inflammatory disease and underwent mastectomy and immediate reconstruction. And by the time she presented to our institution for radiation therapy, you can see how terrible it looks. This is not a curable disease. And what devastating is that this is local disease that is not really treatable. It's very hard to control this type of disease. And should we worry about residual disease after mastectomy, even if our margins are clear? So yes, this is a short commentary that we published with Thorsten at Lancet Oncology, where we discussed the challenging of performing the skin-sparing and nipple-sparing mastectomies and immediate reconstruction. And this is real life data. This is a cohort from our institution of BRCA patients who were treated. We had 3 groups: a group of patients with breast conserving therapy, a group of patients with immediate reconstruction without radiation, because most of them were T10 or DCIS patients, and more locally advanced patients who had immediate reconstruction with post-mastectomy radiation. In all of these cases, the path reported negative margin, but the non-post-mastectomy radiation group, the patients with early, very early disease, we had significantly more recurrences in that group, and those recurrences occurred very early. The median time to local recurrence was 19 months. And you can see, even compared to breast conserving therapy, immediate reconstruction without radiation did poorly. There were significant differences with regards to local recurrence. At 5 years, the breast conserving therapy had 2% recurrences, and the immediate reconstruction without radiation, almost 10% recurrences. This is very disturbing. And should we worry about positive margins and residual disease in case of DCIS in skin sparing and nipple sparing mastectomy? So I would say yes. And I know that DCIS is not invasive lesion, not invading the subcutaneous or skin. But as you can see in this case, this is a case of early recurrence due to residual DCIS in a skin sparing mastectomy and a reconstruction with a diap. So even if the surgeon is doing the resection perfectly, the limits of the anatomic extension of the fibroglandular tissue may be imprecise and may go up to the skin. And this is a nice report that we published with my colleague Trine Tram from the Danish breast cancer group, where she shows in the past slides how the DCIS goes up to the skin, and these cases resulted in early recurrence after immediate reconstruction. And we are speaking about the superficial margin of the mastectomy specimen, which is often not reported in many institutions. And this is a table that we have in our publication. It's a quite large table summarizing the studies that report the margins in DCIS in patients who are undergoing mastectomy for DCIS. And we see that in cases of skin sparing and nipple sparing mastectomy, there was a shorter interval to local recurrence compared to total mastectomy. So we're asking ourselves whether it's due to the superficial margins. There are more recurrences in cohorts that the margins were not reported or partly reported, and significantly more recurrences when in cases of close or positive margins in case of mastectomy for pure DCIS. And you need to remember that according to these reports, in these cases, over 90% of the recurrences were invasive cancer. The ability of radiation after mastectomy is limited to treat residual disease because of the doses. If we want to treat gross disease or a larger foci of tumor, we need to increase the doses, and this will increase toxicity. So if we're not aware of residual disease, or if we cannot exactly locate it, the radiation doses that are given will probably not treat larger foci of tumor. And also, should we worry about biopsy tract recurrence? And this is a case that we have a patient that recurred after skin sparing mastectomy without radiation at the area of the biopsy tract. And we have a few reports indicating that from mastectomy specimen, that in up to 46% of the biopsies, there were residual tumor cells. So I urge you to collect these data, to document, to publish, so we'll have more information how to deal with these cases. So what are the risk factors for poor outcome in case of mastectomy and post-mastectomy radiation? We know that some patients have very challenging body habitus, comorbidities like diabetes mellitus, vascular disease, connective tissue disease are associated with poor outcome after radiation. Some of the patients have susceptibility to radiation therapy and will develop severe complication without any known genetic mutation. And we know that smoking is associated with poor outcome after reconstruction without radiation and significant poor outcome with radiation. And it also increases significantly the risk of lung cancer. We need to remember that most of the patients we treat are curable disease and will have a lifelong to develop lung cancer. So we need to encourage them to stop smoking. And as a radiation oncologist, I'm interested in the area that are my target volumes, and those are the areas of residual breast tissue and high-risk local recurrence. And in this systematic review, we summarize the areas of residual glandular tissue according to the different type of mastectomies. And as you can see in this slide, similar to what Tibor said in the initial presentation, the upper outer quadrant have more glandular tissue in the native breast, but also more glandular tissue after nipple sparing or skin sparing mastectomies. And we also know that the extent of axillary surgery is also associated probably with residual breast tissue. The de-escalation of surgery resulted probably with more residual glandular tissue. And this is a great prospective trial, the Skinny trial, where they prospectively evaluated by biopsy of the mastectomy skin flap, the residual glandular tissue, and up to 50% of the mastectomies had residual breast tissue. And this was 7.1% of the breast tissue itself when they evaluated. And all the factors that were considered, only the surgery type, nipple sparing, had significantly more residual glandular tissue compared to skin sparing mastectomy, and the surgeon expertise were significant for the amount of glandular tissue left behind. And we need to remember that glandular tissue itself is not an indication for post-mastectomy radiation, but it may harbor residual cancer cells or be a source of a secondary primary. And this is from a radiation oncology view. This is a CT simulation for planning the radiation in a patient that underwent skin sparing mastectomy with immediate reconstruction. And per ESSO guidelines, we consider the target volume of the breast tissue is the tissue that is lateral to the perforating thoracic vessels. And this is the part that you see next to the arrow, and you can see that this patient has significant amount of breast tissue in case. And she was treated with a mastectomy and immediate reconstruction. And this is another case of bilateral disease in a patient that did not respond well for primary systemic therapy. She had bilateral disease, underwent bilateral mastectomy and immediate reconstruction. And this is her CT simulation. But when I superimpose when I fused the PET CT on the CT simulation, the PET that was done at time of diagnosis, you can see why I get nervous when I see those CTs when I need to treat. And again, the same patient, when I superimpose the PET CT on the CT simulation, you understand why I get nervous when I see such amount of glandular tissue left, especially next to the area that the primary tumor was on the left side. So also part of the work, we mapped the spatial location of the recurrences, and we also, Thorsten is part of the author group here and contribute a lot for this work. And we saw that the recurrences were related also to the type of reconstruction, but mostly occur in the subcutis or the skin of and at the area of the primary tumor, but the subcutis and the skin of the native breast. So in case of skin sparing and nipple sparing mastectomy, it's in the area of the native breast tissue. And in case of autologous, and in this figure, it's an autologous with the cutaneous, it's a tram procedure. So here we'll see that the recurrences are mostly at the area of the skin and the subcutaneous of the native breast. So as I indicated before, we can define the volume and treat and protect the organs at risk, but we need your help, the surgeon's help, very much in this case, because the surgeon decide with the patient the shape and the size of the implant according to their patient wishes, body habitus, cosmesis, but it also please consider the feasibility of delivering radiation safely when you choose the implant with the patient. In both cases are patients who had unilateral disease and underwent bilateral mastectomy with immediate reconstruction. And due to the size and the shape of the implants, it was very difficult to deliver the local regional radiation safely without exposing tremendously the organs at risk, the lungs and the heart in these cases. So how can your radiation oncologist improve outcome? And we know that the capsular contracture occur over time. So what can we do? And target volume delineation is a very important issue. By well defining the volume and correctly planning the radiation, it is important for tumor control, but also to reduce toxicity, and it needs practice. It's not easy at all. It's very similar like surgeon. The more you operate, the better you are, the more you train. And there are different training platforms like Falcon from ESSO. And these are a few publications that we wrote. And as you can see, we have surgeons on our team as well in order to improve the delineation and treatment planning to reduce toxicity and improve tumor control. And part of considering the target volume, you need to consider the benefit of internal mammary radiation. We had a few trials showing that there is a benefit in patients with advanced local regional disease, but also the internal mammary vessels are the area that the microanastomosis is done to the internal mammary vessels, usually at the area of intercostal 3. And this is usually the area where we target the radiation, and it was found to be associated with more fat necrosis in case of autologous flap. part of the things that we can do to reduce toxicity is to adopt new radiation schemes, dose and fractionation. I know we do not have many trials for moderate hypofractionation in case of immediate reconstruction. We have one published trial in the Lancet Oncology, which was done in China, but we have level 1 evidence for moderate hypofractionation in breast. We know for decades that it reduced toxicity without compromising oncological outcome. And if it reduces the toxicity of the breast, then why not for in case of reconstruction? And this is why we have the St. Gallen consensus for moderate hypofractionation in case of immediate reconstruction, and the upcoming ACROP-ESTRO guidelines that are planned to be published soon. And also, we need to choose the right radiation technique. And in the case of bilateral reconstruction that I showed you before, yes, your radiation oncologist might say it's not a problem, we can use arc-based radiation, but we cannot overcome the physical properties of the radiation beam. So radiation is a trade-off between target volume coverage and organs at risk dose. And we need to remember that if we use arc-based and the different new technique might expose the patient to a low dose of radiation, which we do not know the implications with regards to secondary malignancies. And we have a lot to do with regards to planning. Dose homogeneity is very important. It can reduce the radiation-induced fibrosis. We know that very well. Also, deciding about the doses, whether to boost or not to boost. We have a nice publication from MGH showing that boosting the mastectomy scar is associated with increased complication and implant failure and failure of the reconstruction without improving local control. And similar data we have with regards to the use of the bolus. So after radiation, you need to promote healthy lifestyle of the patient, stop smoking, physical activity. We need to encourage to reduce the inflammation, increase blood flow and antioxidants. And we have a few studies, mostly retrospective, suggesting the potential role of anti-leukotriene antagonist or fentoxicillin and high dose of vitamin E. And these are systematic reviews that summarizing these data, but we need to evaluate these in prospective trials. So we need to work together to create clear guidelines. We have so many questions about the surgical procedures. What is better with radiation, if it's the prepectoral, postpectoral, the use of acellular matrix. We need to train the surgeons, as you can see by the Skinny trial, but also train the radiation oncologist. And we need to report the long-term follow-up and adapt and improve over time. And we also need to support new and innovative initiatives like the Danish Breast Cancer Group trial and trials that are evaluating perioperative radiation before mastectomy and flap reconstruction. And this is another amazing initiative by my colleague, my dear friend, MJ Cardoso. And there are many institutions that are involved. And I hope that this will be the future for surgery and for radiation, that developing artificial intelligence in order to predict to the patient how the breast will look after a different kind of surgery, whether she chooses oncoplastic surgery, breast conserving approach, or mastectomy with reconstruction. So I would like to thank you for inviting me to give this talk. It's a pleasure, and thank you for listening. Thank you.
Thank you very much, Orit, for this excellent overview of the radiation therapy. And I think we are a little late already.
Sorry.
No, it's okay. I would just only want to ask you a question, because we already know the evidence about radiation therapy and reconstruction, but in your practice, what is the percentage of patients that you irradiate with implants or with autologous tissue?
I think we rarely see patients with mastectomy without reconstruction. So most of the patients in our practice have immediate implant-based reconstruction, and only a few have autologous-based reconstruction.
So you usually irradiate implants?
Yes. We treat according to the oncological disease. So if we have an indication to irradiate based on the disease itself, then we'll irradiate.
Okay. Thorsten, do you have any comments before we close the session?
Yes, my first comment is that I really want to thank Orit for this really amazing presentation. And it's not only the presentation, I think it's the entire way that you are performing your research, and that you opened a new window showing that for local region control, we need cooperation between surgeons and radio-oncologists. And you do this really in an excellent way, and thank you very much for this. So I think this is the way we need to discuss with one another, and this is an important issue of this webinar today, bringing radio-oncologists and surgeons together. And I think it's so important to learn, for me as a surgeon, to learn about the problems of radio-oncologists, and also make radio-oncologists understand what are my problems. So I think this is the way for the future, and thank you very much for that.
Yes, I agree. And I think that it's true that we really need to cooperate more closely than we have done before in the past, because this is the only way to de-escalate treatments, really. So thank you very much. I think we'll have to close. Just want to remind you of the 40th Congress of the European Society of Surgical Oncology in Lisbon. It's going to be presential, face-to-face. So all of you who want to be there, we'll be very glad to have you there. And thank you, Orit. Thank you, Thorsten. You've been a great moderator, even in the car.
Amazing, yes.
So hopefully we will have time to do other webinars together. And I'm sure that the participants, thank you for being there, because we have a good activity in the chat. Thank you, everybody, and have a nice weekend.
Great. Thank you very much, Isabel.
Bye-bye. Thank you.
Everybody.
Bye.
It was a great session. Thank
Bye.
you. So, bye-bye.